It's good to be here with you today. And the answer to the question, where do we as healthcare consumers get our information, depends to a great extent on who we are as consumers, what is our condition, and what is our clinical area. So I'd like to share with you some things that we've been learning at Childbirth Connection to ask you to think about how your community might respond and to encourage you to consider carrying out similar investigations to what we have been able to do. We are longtime Q members. I think most of you know us. We're 95 years old this year. And throughout that entire time, we've been working to improve maternity care quality on behalf of mothers, babies, and families. And our focus right now is on consumer engagement and health system transformation. We've been privileged to carry out 3 national Listening to Mothers surveys over the past decade, working each time with the same core investigator team and with Harris Interactive. Harris developed and validated our methodology, which includes online panels, quotas, and data weighting for demographic variables and the propensity to be online. The surveys give us a chance to monitor trends over time with continuing items and also to switch in new and timely items as the environment changes. And we have gone back to the initial participants in the second and third surveys with a follow-up survey, leaving us with a very rich combined database from before pregnancy through well into the second year postpartum. Today, I'd like to focus on our most recent Listening to Mothers 3 surveys. We reported those main reports just in May and June of this year. So the matter of information sources has multiple dimensions, and I'd like to share some of them that we've been looking at. First, some sources will be valued and trusted more than others, and it's important to know where consumers come in on this. Here we see the proportion of first-time and experienced mothers who rated as very valuable these various sources among those who used them in their recent index pregnancy. And the maternity care provider came out on top and is actually the only one that grew in ratings over time as the women had their personal life course experiences. Childbirth education and pregnancy and childbirth websites were the next 2. Turning to some popular online sources, we found that pregnancy and childbirth related blogs were most used among the various popular sources you see here, and also were most highly rated as valuable sources of information about pregnancy and childbirth. Now, we asked a hypothetical question about the trustworthiness of various sources because we were eager to understand how people might think about some sources that they may not have used yet. And for example, can we use electronic health records and personal health records to deliver certain kinds of content? And what's really notable here, of course, is the outlier status of the maternity care provider, with almost half giving this unqualified choice of this person would be completely trustworthy. And again, childbirth education came in second there. So a related dimension is the information channels that consumers have access to and how they view those as sources of information. We were eager to understand how wired our population is, and virtually all have internet access. Now, this is going to be influenced by our methodology. We, in previous survey, were able to complement the online survey with a telephone survey, and we were not able to do that this time. However, we do know that this population, and young moms in particular, are very active users of various online sources. And of those using the various devices, those who rated as excellent, they rated laptop and desktop computers as excellent more so than others, but also tablets and smartphones and iPod touches with internet access were also viewed as reasonably good sources of pregnancy and childbirth information. So turning to information sources themselves, I'd like to mention that our previous surveys looked at more traditional sources like books, films, friends and relatives, and for experienced moms, their own experiences from what they learned in the past. And we didn't have enough space to include those, but we do have them in previous surveys. We were pleasantly surprised by the encircled results in this and the following slide. A large proportion of our survey participants consulted online sources of information about specific maternity care providers and specific hospitals. And what you see here factored that information in to their decisions about these very consequential choices. So while our Medicaid condition does not yet enjoy the benefits of, for example, hospital compare and physician compare, which are primarily oriented toward Medicare conditions, this bodes very well for continued progress on public reporting of performance measurement. And we're very happy that the Joint Commission core perinatal measure set will be mandated to report by hospitals with over 1,100 births per year next year. So as we saw, childbirth education is highly valued by those who use it and is considered to be quite a trustworthy source of information. However, we know over time that use of childbirth education has been dropping off. So that this time around, either in the present pregnancy or in any previous pregnancies, not even half of the moms had taken any childbirth education classes. And moreover, we learned that the format of the classes is being condensed into 1 or 2 days, and quite a few women are getting hospital-based classes where the focus is on what will happen to you as opposed to what choices you may want to make and what kind of preparation you may want to give. Another relevant dimension is whether the health system is reliably providing what we might consider to be essential kinds of information. And here you see that among women with any postpartum visit, quite a few did not receive, according to their reports, any information on such consequential matters as appropriate contraception, care for depression or screening for depression, and what would be a healthy pregnancy interval if they're planning to get pregnant again. And these did vary by the type of provider. So bear with me on this next slide. 3 of our question sequences were adapted for maternity decisions from those that have been applied in other clinical areas. And in all cases, and the purpose was to assess whether the decision-making processes were well aligned with what we understand as appropriate standards of shared decision-making. In all cases, women reported being steered toward interventions, and that is exactly what has been found in other clinical areas. Not shown here are sequences about being encouraged to have labor induction or a primary cesarean when the fetus might be getting quite large at the end of pregnancy. And neither of these are supported by best evidence. You should not intervene, you should wait for labor or until there is some compelling reason to intervene. And here we see providers overwhelmingly recommending a repeat cesarean, and women overwhelmingly getting a repeat cesarean when they had had 1 or 2 prior cesareans, despite the 2010 NIH Consensus Conference recommending access to VBAC and the revised ACOG guidelines saying that most women with 1 or 2 prior cesareans should be offered a vaginal birth after cesarean. Now, this is a little easier way to look at the skewed nature of this information in this process, and most notably, only 3% reported that in this conversation they had been given no information at all about why they might want to have a repeat cesarean, whereas 40% said, I received no information at all about why I might not want to have a cesarean. And this despite the mounting evidence of the hazards of repeated scarring over time for mothers and babies in future pregnancies, the increasing awareness of the association of cesareans with a series of chronic childhood diseases, and other concerns that should be causing us to think twice. Another dimension is the experience of seeking information, and we focused on online searching here. And while mostly a positive experience, we found that notable minorities felt that they could not make appropriate decisions on the basis of what they found online, or were not really prepared to have conversations with their care providers about this information. Others felt overwhelmed by the volume of information, frustrated by not finding what they wanted, and frightened or confused by what they found. Our surveys also allow us to consider participants' knowledge, assets, and deficits. So with this landscape that we're seeing, what do women know? And in the case of the American Academy of Pediatrics recommendations for optimal duration of exclusive breastfeeding and duration of continued breastfeeding along with other kinds of food, their answers were really very close, whether they had breastfed or not, to those recommendations. However, we wince at the proportions who were retelling us that, in general, newer is better. Providers are reliably offering evidence-based care. More care is better, and more effective care is likely to be more costly. And we certainly would like to see better understanding of the problem of overuse that is out there. And here's a troubling knowledge deficit about the timing, or that applies to the timing of the many labor inductions and planned cesareans that we are seeing. About 44% of the moms actually identified weeks that we would consider preterm as the safest, earliest time to deliver a baby. And an additional 35% identified what we would now call early term, when we have an increasing understanding that the fetal lungs, heart, brain, and other organs are continuing to develop, and the optimal care is to stay put whenever possible. Whether the women had a cesarean or not, the majority did not recognize either the hazards of repeated cesareans or the respiratory risks to newborns in cesarean births. And similarly, the majority did not correctly indicate that it is ill-advised to induce labor if the baby seems large. And not blaming women here, as you saw from the shared decision-making sequences, they really haven't been getting good guidance on this from what we understand. Our surveys identified repeated concerns with the quality of maternity care, and I've only had a chance to touch on the concerns that we identified, but nonetheless, the moms rated the maternity care system very highly, and in fact, quite a bit higher than the healthcare system overall. So finally, can we assume that good knowledge will lead to appropriate action? And confirming other research, the moms told us that they would like to know quite a bit in detail about the harms associated with various things that they're considering. They like to know about the option of what we would call watchful waiting, not doing anything, and as opposed to intervening. They'd like to know what the cost implications are to themselves. However, the majority say, in general here, that they want their care providers to make their decisions for them. So what we've been learning are that there are many dimensions to healthcare consumer information sources, that these may vary across clinical areas and consumer groups, that there's the potential for great flux over time, and that valid, up-to-date surveys can provide valuable insights. So this knowledge is crucial for our strategy as an organization, and I would strongly encourage you, if you get the opportunity, to start to look at some of these issues for your own populations. Thank you.